I'm a pharmacist by profession. I work with the pharmacy board in the Department of Product Safety. Specifically, can you hear me?
Yes, we can hear you.
Yeah, I hope my internet will behave. Focal point for post-marketing surveillance, which looks at quality of products, but also antimicrobial resistance, which I'm very passionate about. And I've specialized in pharmacoepidemiology and pharmacovigilance. So I have a lot of passion on safety of medicines. And I also believe antimicrobial resistance is actually part of pharmacovigilance and post-marketing surveillance. So I want to welcome all of I've been meant to understand this audience is a university.
Dr. Wanga, it seems like we're losing you. Dr. Wanga, we can't hear you.
So Paul, you can still hear. Janice, confirm that you can still hear me.
Yeah, we lost you briefly, Dr. Wanga, so maybe you can just repeat.
Yeah, okay. Yeah, so I was saying I'll give a bit of the context, global, and also in our local context, which is Kenya, and also low middle income countries. So I'll share my screen. Just, this internet is great today.
There's no way you guys are actually beating Leicester.
Okay. Yeah, so you can see my screen, hopefully. I'll talk about, you can see my screen?
Yes, we can see it.
Okay, thank you. This slide is mostly focused on the status, AMR status in Kenya, but I know that we are not very different from other LMIC countries, especially now that we have been interacting with them and we also have an idea of what they're doing in those countries. So I think we are not very far from each other. And I believe that this presentation will actually reflect, will be able to reflect what is happening in other countries. So I'll have introduction, background of AMR in Kenya, the national policy and action plans, implementation status, and collaborations. So we all know that antimicrobials play a critical role in saving lives in humans, and not just in humans, also in agriculture, maybe animal production, for both therapeutic and non-therapeutic. And we also know the role of antimicrobial agents also in crops production. Also in environment. Kenya, we undertook a national analysis in 2011, and this was updated in 2016. And also, this situational analysis established that AMR is a threat to us as a country, just as it is a threat at a global level. So in terms of the issue at global level, we have had a lot of media coverage on the threat of antimicrobial resistance. Some people say it is going to be an apocalypse. It's going to be a bigger pandemic than COVID-19. And in terms of scale of impact economic, media has reported that superbugs pose a dangerous 65 billion threat to the US healthcare system. So you can imagine that economic costs of this issue of AMR. And then in terms of the scale of impact on medical systems, antibiotic resistance could spell medicine, says a chief medic, it was reported. And in another report, it was reported that antibiotic resistance, huge fears for end of modern medicine. And you can understand why they're talking about end of modern medicine. And then 10 million lives could be lost to superbugs. So how far have we got in the race to beat them? In the terms of scale for death, there's another one that, can you still hear me?
Yes, we can hear you.
Okay. Yeah, so in another report, it was reported that antibiotic resistance could take us back to the days where 40% of us died of infections. That's actually pre-antibiotic era. Then also taking antibiotics unnecessarily could cause more death than diabetes and cancer combined. So another report was superbugs are going to wipe us out before climate change does, expert warns. Why antibiotic resistance is now our planet's biggest health issue or health concern. Another report, how antibiotic resistance could take us back to the dark ages. Antibiotic apocalypse. Doctors sound alarm over drug resistance. And then in another report, where they're talking about who it affects, E. coli in children, doctors fear antibiotics have stopped working. And also in another report, it says statins have power to help elderly fight off killer superbug. So you can see there's a lot of reports in publications, in the media, in other forums, people concerned about the issue of antimicrobial resistance. So really, it's a global concern that requires both global and local action and collaborations for all the sectors that are concerned, and that is the human health sector, animal health sector, the environment, so that we can be able to move with what they call the tri-cycle. So I've already talked about the situational analysis in Kenya. That was the context then, that 50% of causes of mortality were infectious diseases. And we all know that we use antimicrobial agents to manage infectious diseases. And also that analysis showed there were rising trends of resistance. We had weak laboratory capacity for microbiology, and we had limited data in terms of antimicrobial resistance, antimicrobial use, and even consumption. We didn't have any data by then. So what are some of the drivers of antimicrobial resistance? As you might be aware, prescribers and patient behavior. I'll give you an example. If a mother comes to see a pediatrician and she already knows that last time she was given amoxicillin clavulanate, say Augmentin, it worked for the child, sometimes they will insist that they want Augmentin. So they come in and they have already decided what they want from the doctor. So that is patient behavior. In terms of prescriber behavior, we have seen cases where a prescriber is giving combination of two antimicrobials, which actually antagonize activity of each other. And sometimes giving more than antibiotics that do not have indication. We have seen when we carry out point prevalence surveys even in our big referral hospitals, you have a lot of prescriptions that do not have indication. So that is one of the drivers of antimicrobial resistance. Weak healthcare systems. For example, in low-middle-income countries, a lot of people are not able to access a doctor to be able to get a prescription. So what do? They go to the pharmacy on the counter and they get the antimicrobials there over the counter. So of course, that also speaks to weak regulatory systems in terms of how we control access to medicines. Non-human use of antimicrobials. In fact, some reports show that the use in animal is much, much more than the use in human health. And also some people have used antimicrobials as growth promoters and even for crops. And all these contributes to issues of AMR within the environment and emergence of new strains, resistant strains. Technological development, of course, we know that I can be speaking to you now. In the next 6 hours, I could be in the Middle East, or I could be in another part of the world. So that very fast movement of people enables also moving the pathogens, resistant pathogens from one part of the world to another. So you can see that photo, food handling practices. We all know how our abattoirs look like, the kind of hygiene that you will find in those places. These actually contributes to transmission of those pathogens, sometimes even from the food chain to human beings and from human beings to human beings, and animals, animals also to human beings. So in terms of the cycle, you can see all that. There's a human being, there's the environment, the sewerage systems, there's the farm, what happens at the farm level, farm level practices. We have manure from our animals, we have the food, from the animals, and then we have the antimicrobials themselves. So there's the whole cycle that is interwebbed and very closely interfaced with each other. And what happens in one area potentially will affect the situation in another sector. We also know about zoonotic diseases. We know that in some parts of the world, people still eat these wild animals, what they call wild meat. Even in Kenya, there's still some parts of the country where people eat this wild meat. And that is potentially a source of zoonotic diseases. And some of these zoonotic diseases actually are contributing to resistance. We all know also about COVID, the explanation that has been forwarded about how COVID came about. Some people say it might have been through this wild meat. So it's actually a threat. As much as we are having close interaction with those wild animals and also with the environment, we are likely to be affected. So what are the consequences? Okay, so based on that situational analysis, and also based on developments that were happening at global level, where there was development of the global action plan to address the issue of AMR. Countries also were encouraged to develop their own national action plans able to address AMR within their countries. And a lot of the national action plans were actually aligned
Could you make me host so that I can mute you?
There's quite a lot of background noise.
Make me host so that I can mute them.
Okay, just a minute. Yeah, I think it's now better.
Yeah,
Can we just continue?
Yeah, let's continue.
Okay, so this is how we scored in our joint external evaluation. We didn't do well in terms of detection of antimicrobial resistance, surveillance systems, healthcare associated infection prevention and control. We also know that there's a lot of healthcare associated infections that our patients get from our healthcare facilities. Of course, because of issues of infection prevention control, which are not being properly implemented within our healthcare facilities. Then antimicrobial stewardship, this is very key. And it's a whole area of AMS. So as Kenya also, we are putting in strategies to see and address the issue of stewardship, both at facility level, at county level, and even at national level. So what are the guiding principles in terms of how to tackle resistance? So one is consistency and compliance with guidelines. We shall see that we have developed quite a number of guidelines to be able to help us make activities that would be important in terms of strategic interventions to address resistance. Number two, One Health approach. And I think that's the topic that you really, I know, have gone broader, but I know you're focused on One Health approach. However, this One Health approach is embedded in other broader principles that we need to be able to discuss together for us to achieve maximum impact. So One Health approach is very critical. Alignment with global action plan, prioritization and stepwise approach. You cannot be able to, handle everything at once. You cannot be able to chew more than you can swallow. So you have to prioritize, and you have to have a step building on the, the blocks and creating impact. So prioritization is very important, and then that stepwise and incremental approach, and just having a proper monitoring and evaluation framework so that you are able to monitor and track impact. Then multi-sectoral approach and coordination. This is very key, and it still speaks also on One Health. You must be able to coordinate across sectors, because this issue is multi-sectoral. For example, whether there are people in the environment, whether there are people in animal health sector, agriculture, livestock, and of course, human health sector. And even within human health sector, there are many players need to be coordinated in all those sectors. So intersectoral coordination is very key in terms of how you approach these issues. So we came up with our own national action plan on prevention and containment. That is 2017-2022. It's actually coming to an end in 2022. We should be thinking of another action plan, or we should be looking to see what we have been able to do, what we have not been able to do, how we can be able to mitigate that. Those are just photos of the launch of the National Action Plan and National Policy. Those are the cabinet secretaries, both from agriculture and health. So you can see that is One Health already. This joint launch of the National Action Plan that is cross-cutting both in agriculture, livestock, and also human health sectors. And the white man there is the country representative of WHO, Dr. Eddie Regis. So we had also a lot of collaboration with the global community, especially the World Health Organization, the Food Agriculture Organization, and also Organization of Animal Health, World Health Organization of World Animal Health, the OIE, I think it's called Organization of World Organization of Animal Health, yes. So all that you can see, it is One Health. So as we have said, AMR is complex. It's one of the most complex public health challenges that we face in our time, because it has many interdependent factors, interplay and interconnection of multiple factors. And therefore, it's very, very complex. So no single organization or government sector can actually be able to address this issue on their own. And you need collaboration and the coordination across sectors. That just speaks to One Health, why we really need to emphasize the issue of the issue of One Health. And then also there has to be deliberate coordination, effort to coordinate and collaborate for all the sectors. And then bringing together stakeholder groups, government, civil society, and even the private sector in academia. For example, today we are talking with you, and you are all you are from academia, and tomorrow you'll be the ones who are practicing, because we also need to really build a culture of stewardship within communities of practice. So you are pre-service today, but tomorrow you'll be in service and you'll be practicing, and you'll be part of the community of practice, which is very, very key. So in terms of implementation stages, there is the exploration, where you do your needs assessment, you assess the drivers of AMR within your countries, assess strategies that best fit your context, and then installation. Installation is where you go and look at resources. Resource mobilization is very key. Coming up with guiding documents like the National Action Plan, and then looking at the drivers of implementation, focusing, having focal points within organizations who will be driving the agenda. So that's staffing norms for AMR. And then you move into implementation. So that's initial implementation. Again, you adjust the drivers of implementation. You manage change if there is any change. And there's a whole concept of theory of change within AMR. Maybe some of you can be able to go and read theory of change in AMR. And then creating surveillance systems to be able to generate data. And then having improvement cycles and monitoring and evaluation to be able to identify the gaps, address those gaps, and learn lessons that can be able to help improve in terms of building the systems. And then moving to full implementation. Most low middle income countries are at the level of initial implementation. They already have established their national action plans, which are joint action plans from the human health sector, animal health sector, and the environment. And now they have started implementing some of the strategic objectives and interventions. Some countries in the world, for example, Sweden, and even some countries in Europe, they are already at full implementation. So they have seen impact in terms of the intervention that are put in place. For example, Sweden was able to drastically reduce consumption of antimicrobials. They had, at some point, they had very high use of antimicrobials in pig farming. So they put in measures to be able to reduce. And I think they almost brought it down to from about, in terms of percentage, they brought it down by almost 70% consumption, just by adopting very good farm practices, farm level practices in what they call animal husbandry. So those are very key lessons that we can learn from other countries that are ahead of us in terms of the full implementation. Advocacy is very key, even as we talk about One Health. Joint advocacy is very important. And this has happened especially during the World Antimicrobial Awareness Week. We all know that the WAWI Week is coming up just this month in November, the month starting on Monday. And so it's a very important month, and that WAWI Week is very important because then we create awareness. And for Kenya, we have done the preparations jointly. Even now, we are sitting in a lot of meetings, planning together with our counterparts from the environment and also with our counterparts from animal health sector, planning together for WAWI Week. And when we celebrate this WAWI Week, we also celebrate it jointly. So we have joint symposium where both representation from animal health sector, human health sector, they come in to showcase any scientific work that has been done, any breakthrough work that has been, groundbreaking work that has been done around AMR. So all that is done jointly with our counterparts in the other sectors. And that just goes to speak on One Health. And then we have sensitization of communities or general public. And we also have what we call farms. People go to the farms to also sensitize. Open days, actually they're called farmers open days for farmers, where they come and they're sensitized. They're told about vaccination, because vaccination is better. It helps to prevent as opposed to treating those animals. So they are taught about farm level good practices and all that. And there's an exchange. We have people from human health sector going to participate in open days, or those open days for farmers. And you also have people from the animal sector coming to participate in sensitization of the public on issues, for example, for infection prevention and control. So there's that cross-breeding just to enhance the concept of One Health approach. This was in 2019, where we had what we call the tripartite. The tripartite comprises of Food Agriculture Organization, World Organization for Animal Health, and World Health Organization. So you can see both representation from the animal sector, human health sector, and the environment. And we had the continental level tripartite who came to Kenya in 2019 to celebrate the World Antibiotic Awareness Week. And actually that One Health approach was really emphasized in this tripartite meeting that was held in Nairobi in November 2019. That's just signatories. What you've seen there is people signing, making their commitment that they'll be able to contribute to fight in stewardship of AMR. I also happened to participate, you can see there, giving my address in that tripartite meeting of the World Antibiotics Awareness Week in 2019. Also, in terms of student clubs, maybe some of you can see yourselves here. We have a lot of students participating in what they call One Health student clubs. And they have really helped us to demystify AMR messages using music, using drama, using skits, using other communicating to the public and also to other students. And that is really key, because these messages need to be demystified. We need to bring it to the level of the general public so that they can be able to appreciate and be conscious about it, and own it and say this is a problem that is for all of us, so that we are part and parcel, and they need to do their bit in terms of their practices, in terms of their behavior, because behavior is really, really important in terms of how we can change the direction on stewardship of antimicrobial use. So you can see this is a field day, open field day for farmers. And some of us who are from health sector, we actually participated in that field day with the farmers. So you can see the One Health kicking in as we do those collaborations. So in terms of the World Antimicrobial Awareness Week, again, jointly organized by the FAO, the OIE, and the WHO. They have all the different themes coming together to develop one theme for the World Antibiotics Awareness Week, and just working together to develop materials, for example, information, education, and communication materials, posters, and all those things that can help to send the messages to the general public, to the healthcare professionals, to the farmers, and all the stakeholders that are really important for this fight against AMR. Some of the IEC materials are there, talking about issues of resistance in animals, what you need to know about resistance in animals. For example, one of the IEC materials says antibiotic resistance is caused by inappropriate use of antibiotics. Do not treat animals without seeking professional advice. Give the full dose of antibiotics. Always store medicine as recommended by the manufacturers. Do not use expired medicine. So that is just one of those that is used in animals. And then, of course, we have another one in human health sector that says do not misuse antibiotics. Antibiotics do not treat every illness. We have seen in COVID-19 pandemic, we all know that COVID-19 is not a bacterial infection. And yet, a lot of people have actually been self-medicating using antibiotics. I mean, azithromycin has been extensively misused because people think that it will actually treat COVID-19. So that misinformation and that misuse of antimicrobials can actually be a major contributor to AMR. Do not share antibiotics. I know even among yourselves, maybe some of you share antibiotics in the family. You get your dose, after 2 days, you feel better, you keep it. Your sister, your brother, or your boyfriend or your girlfriend, they have the same symptoms. They also go and take those antibiotics and they continue using them. So those are some of the practices that can contribute to antimicrobial resistance. We know the impact in terms of costs. Prolonged treatment, prolonged hospitalization because of resistant strains of pathogens can be very costly, where the healthcare costs can really be driven over the ceiling just because of antimicrobials, and also the healthcare associated infections. Those are very key in terms of the costs of healthcare and also spread of resistant strains, and of course death. AMR is responsible for a lot of death when all the antimicrobials that are available are not able to treat your infection. Then ultimately you will die. What will happen is that ultimately we'll lose the patient. So these IEC materials are very important in terms of messaging to the public, to healthcare professionals, and to everyone who is part and parcel of this fight. So there was a survey that was done in Nairobi, and I'll just sample one of the questions and not look at all the questions. So one of the questions was, would you change your doctor or your pharmacy provider if antibiotic is not prescribed? Would you change your doctor or your pharmacy provider if antibiotic is not? And 49% of the respondents actually said that they will change their doctor or their pharmacist if an antibiotic is not prescribed to them. So you can imagine the kind of attitude and behavior that our patients have. In another survey, in the same survey actually, one of the respondents was quoted, says, I once visited a chemist and observed what was happening. A 10-year-old walks in and asks for medicines by name. I asked the provider, have we all become doctors? I used to see the doctor writing a prescription for us. The provider said that in Isli, there's no need for doctors. Everyone is a doctor. So this is the kind of this is the kind of response that we were getting when when this survey was done. So that provider says that in his fee, you don't need to have a doctor because everyone is a doctor. Okay, so that is the situation that we are faced with, and we need to reverse these beliefs. We need to reverse these attitudes. We need to reverse these practices. We need to empower people by giving them knowledge and telling them that these are real threats. It might be a bigger threat than COVID-19 itself. And I know people will be able actually to prove that AMR is a bigger threat to the world economy, to public health than even COVID-19 itself. So again, that is just launch of documents. We have done a lot of guiding documents in terms of guidelines to be able to support the work that we do. Those are just many guidelines that we have come up with. There's the National Antimicrobial Stewardship Guideline. That is very key because it talks about what we need to do so that we can be able to implement stewardship. What are the role of healthcare professionals? What are the role of procurement, the people who procure medicines? Also, in terms of dispose medicines, can actually when these pharmaceuticals are discharged into the environment and end up system, they end up chain. They could cause what we call a selection problem, and that can easily lead to emergence of resistant strains with the environment, which can easily be passed on to animals and also to human beings. So it's very important that even disposal of waste is very important, whether it is at at farm level or at healthcare facilities level in the environment. We also have the Kenya National Infection Prevention and Control Strategic Plan. IPC is very key. Some people say IPC is not AMR. Some people say IPC is part of AMR. Some people say IPC is on its own AMR. But we know that these are very closely interconnected. If you don't have very good IPCs or IPC even in a hospital, there'll be a lot of emergence of health care associated infections within the hospitals. You have a lot of treatment failures because you have emergency of resistant strains. So IPC is very key. And we have seen level of compliance in terms of IPC during COVID-19 really go up, which is a good thing. There's a lot of hand washing, there's a lot of use of alcohol-based hand sanitizers, there's a lot of, all that people are careful in terms of infection prevention and control. And there's training also, a lot of trainings have been done for healthcare workers to implement IPC. So IPC is very key for us to control resistance. And it's not just in human health, it's also in animal health. How they take care of the animals, where they stay, if it is poultry, how you ensure that as you keep your poultry, hygiene, basic hygiene is maintained, the water that you give to this poultry and all that, it's part of IPC. And that could go a long way for us to reduce dramatically on use and misuse of antimicrobial agents, which is a major driver of AMR. Then we have diagnostic stewardship. The diagnostics, we all know about, maybe you've heard of point of care diagnostics. These are very key because then they guide the clinician on what to prescribe. They will guide the veterinary surgeon or veterinary doctor on what to prescribe to the animal, because then they have a diagnostic that can quickly be deployed and can quickly give them results. So they have evidence-based. They're able to know that this animal or this patient has a bacterial infection, and this type of, they're able to identify that bacterial pathogen, and more important, even to do what we call antibiotic susceptibility testing, AST, to check whether that bacteria is susceptible to antimicrobial or and able the of treatment that you can be able to use, and that will really be able to help us minimize emergence of new strains. With just the work that I do. So important for you guys is the launch of antimicrobial stewardship pre-service curriculum. Pre-service curriculum. So this curriculum actually is going to be deployed in medical schools to be able to train pre-service, to be able to train students before they graduate. They'll have a whole training and it will be examinable. Once universities ratify and they include them in the mainstream curriculum, it will be examinable topic. And therefore, even at the time you graduate, you'll be able to be equipped with knowledge and skills on antimicrobial resistance, which is an important milestone for us as a country. So in terms of surveillance, and this surveillance, again, should be approached in the context of One Health, so that the strategy that we developed is not in human health or animal health. It is a national antimicrobial resistance surveillance strategy. It is for both human and animal health. Because if you have a very good surveillance system in animal health, and you have a very poor surveillance system in human health, then actually it is counterproductive, because what happens in animal health sector affects what happens in human health sector. And therefore it's important to have a common strategy between the animal health and human health, and just to go through that One Health approach. So we have a surveillance strategy. Implementation is in progress. In terms of AMR data, when I talk about AMR data, these are resistant patterns to just check which are the pathogens. And WHO has what you call a priority list of pathogens. Yeah, and it also has a priority list of antibiotics. So based on this list of antibiotics and this list of pathogens, the likes of E. coli, okay, then you are able to carry out what we call antimicrobial susceptibility testing, AST, and report on the trends, which pathogens are resistant to which antimicrobials, which pathogens are resistant to which. So that kind of data, to be able to generate that data, you need to have good microbiology, yeah, very good bacteriology, lab, that has the proper equipment, because you need the equipment, you need the machines that can be able to carry out AST, you need the discs, you need the supplies, you need the training, okay? You need the samples, you need to train people on how to handle those samples so that you have quality data, because quality data is very key in terms of interpretation. So we have many facilities that have bacteriology in the country, but only so far we only have 6 that are submitting data to the national database. And this national database is based at National Public Health Laboratories. But we are also receiving data from the animal sector, also in terms of AMR data. The goal is to have at least 28 sites by 2022. This is a joint supervision of microbiology lab in Machakos County Referral Hospital. Maybe some of you can be finding the on the far, the far left, the far right, he is actually a veterinary doctor. He's a epidemiologist, he's a veterinarian, and also an epidemiologist in animal diseases. So we're doing a joint supervision with the gentleman who is a veterinary surgeon, and the lab that we were doing supervision was a human health. So you can see the One Health approach that we are adopting as a country. This is again at the laboratory, and we are all, because those are clean areas that you need to be able to gown before you go in. Again, this is infection prevention and control, which is so you have to gown and change over even your shoes from your street shoes to the shoes that are inside the laboratory. So in terms of sites, you can see we have enrolled the surveillance sites. So not all the sites that have been enrolled are actually reporting data, but we are building capacity together with partners, both for human laboratories and animal laboratories, to be able to have enough capacity, enough equipment, enough training, enough supplies, enough infrastructure to enable them generate and report AMR data. And we are projecting that we'll have 28 by 2022. IPC strategy, as I had said, IPC is very key. It's closely intertwined with the AMR. So we have trainer of trainers, TOTs, been trained in 44 counties with basic IPC. By now, I believe all the 47 counties have been trained, and they have trainer of trainers. And this trainer of trainers go and do a cascade training to build capacity at county level. And for healthcare workers from the healthcare facilities are also trained. They also have an ECHO platform. This is just a virtual platform where they meet routinely to exchange good IPC practices and share experiences and lessons learned. And also, of course, that with that, it goes what we call continuous quality improvement for IPC. CQI, as I told you, quality is very key in terms of IPC processes and also AMR processes. So you need to mainstream quality for you to be able to generate quality data. The other very key strategic objective is optimizing use of antimicrobial agents. So we have guidelines for prudent use in animals settings. So we have a guideline for prudent use of antimicrobials in animals and healthcare settings. We have also been able to categorize antibiotics according to WHO aware categorization or classification in what we call a Kenya Essential Medicine List. This is a national essential medicine list that says these are the molecules or the medicine that we're using in the country, for different indications. And it also gives the levels, what can be found at level 6, which are the national referral hospitals, and what can be found at level 1 and level 2, which are the dispensaries, the lowest healthcare facilities. So that categorization is called the Kenya Essential Medicine List. And within this categorization, we have included the AWARE classification. AWARE means A is for access, WA is for watch. Access is these are the products that people need to easily, not really easily, but they need to be available, because either they are used to treatment of common infections or they are life-saving, so they have to be available for people to access. In Africa, as much as we're talking about antimicrobial resistance, it's a problem because of resources. Some people might genuinely require an antimicrobial agent, but because of resources, they're not able to access that antimicrobial agent. And that could actually also contribute to resistance. So access is very key. Then watch are these ones that should not be readily made available, because maybe they're used to treat very rare infections. And again, some level of control and stewardship is required so that we preserve them. And then reserve, these are what we call the last resort antimicrobials. And an example is colistin, colistin and the carbapenems. These ones are in the reserve because they are last resort. And because the pipeline, the development, antimicrobial pipeline development is dry, there's nothing coming through the pipeline. That means that the little that we have as last resort, if we exhaust them and we develop resistance against those ones, then we run out of options. We get to a point where you have nothing to give your patient after they get certain infections. And we are already seeing in TB, all of you have heard of multi-drug resistant TB. There's another one called extremely resistant TB, extremely drug resistant TB, XDR. So when we are already at extremely drug resistant TB, then we have to be really worried, because for those patients, there's no regimen that works for them. Once they get to that level, you tell them to write their will, because really you have nothing to do. So we don't want to get there. And for some pathogens like TB, we already are seeing those problems. And then stewardship programs, those are very key in terms of optimizing use of antimicrobial agents. We also have MTCs, medicines and therapeutics committees. These are very key governance structures that will put in programs and implement programs for stewardship. The medicines and therapeutics committees. We have the national MTCs and we have county MTCs, and now they're being rolled out at facility level. Okay. And then also consumption at pharmacy and poison. We are already rolling out a project where we are monitoring consumption, especially looking at import data and also data from local manufacturers, just to estimate how much are we consuming as a country. For example, how much amoxicillin are we consuming as a country? Maybe every year or in different years, we want to compare and see how much are we consuming. Is it increasing in terms of consumption? Are we reducing consumption? Are we on a level consumption? So all that requires for us to monitor consumption data. And that can help us to make policy decisions that will go a long way in making interventions for optimal use of antimicrobial agents. Prescribing patterns and compliance with guidelines. It has been shown that a lot of facilities do not comply with treatment guidelines, prescribing guidelines, they don't. You'll find that people continue giving antimicrobial agents to patients even after they have done a clean surgery that is not contaminated. They will still continue prescribing antimicrobial even 7 days after surgery, even 14 days after surgery. And in some of those surgeries are clean surgeries that actually don't require post cases where immediately at admission, patients are given an antimicrobial agent. Even before you carry out and sensitivity, you have initiated antimicrobials. And actually this study showed that 12.38%
Excuse me, guys. Is anyone able to see Dr. Wanga's
Yeah,
screen?
I think you lost me. You lost me a bit, and sorry for that.
It's okay.
Just that I'm in a place. In a place where internet is not very stable.
Okay. Yeah, we can see.
Struggle a bit.
Can anyone see Dr. Wanga's screen? Kindly confirm in the chat if you can see his screen. Oh, okay, thank you. Let's give him a few minutes to join.
Please confirm if you can see my screen.
Yes, we can see it now.
Okay, there's a bit of interruption. Really, my apologies. So in terms of guideline compliance, again, quite a number of facilities are not complying with the treatment guidelines. There's a lot of empirical prescribing without evidence. And a study was done at one of the national referral hospitals in Kenya. So compliance is still very low to the guidelines, prescribing guidelines. Also, just another study that was done at Nyeri County Referral Hospital. About 25.3% had no documented indication. That means there was a prescription, or there is an antibiotic or an antimicrobial that was prescribed for this patient in their treatment sheet. But those antibiotics did not have, there was no indication that was documented. Okay. And again, it found that 31.5% recommended, for only 31.15% recommended a first line. So that means they were able to move to second line or third line without really starting with the first line treatment. And also it found that that in pediatric population, only 38.1% had 38.1% had no documented indication. That means there was treatment, but there was no indication. That's in pediatric patients or population. Ideally, you should have more of access antibiotics as compared to watch antibiotics. So watch should be a smaller percentage, and then access should be a bigger percentage. And then reserve should be the smallest percentage. There, and yet this study found that it found that we have more of the watch antibiotics. So we're using more of the watch antibiotics as opposed to access antibiotics. We also have regulatory actions in support of stewardship. We have pharmacies which are closed down, especially those ones that are being superintended or managed by unqualified personnel, or they're not licensed by Pharmacy and Poisons Board. And I know also our colleagues within the veterinary sector, also they carry out inspections, I think through the Kenya Veterinary Board, to be able to check all those outlets that keep veterinary medicines, that they're able to comply with the licensing and also good distribution practices. So that's part of the, in terms of testing, as part of the stewardship, we are also continuously carrying out surveys to collect samples of antimicrobials. Recently, we did one for azithromycin, both suspension and tablets, and because of the issues of misuse and abuse during this COVID-19 pandemic, we wanted to check the quality, and we targeted azithromycin. We collected both the tablets, oral dosage, the oral dosage forms, the tablet and the suspension, and we tested to check quality. So this is important in terms of stewardship, because sometimes you might blame and say maybe the bacteria has developed resistance to the antibiotic, and yet the antibiotic is of poor quality. If it's of poor quality, it will not work. If it's of poor quality, it will not work. So you must rule out quality even before you start talking about the issue of resistance. And also poor quality can contribute to resistance. How? Because once you expose the pathogen to quantities or levels of the antimicrobial which are below what we call the minimum inhibitory concentrations, MIC, once it's less than the MIC, then that molecule or that medicine will not be able to treat or cure or kill, will not be able to kill the pathogen, okay, or the bacteria. And if it's not able to kill the pathogen, then that pathogen is likely to develop resistance against the antimicrobial or the antibiotic. And therefore, it's important that quality of the antimicrobials is assured and ensured for products that are on our market. And I know also that through another funding that is jointly being done by that is the FAO, the OIE, and the WHO, there is funding to carry out similar quality survey for medicines that are used in animal health. So you can see that these efforts actually, One Health, we are trying to address both human health sector and also animal. There's funding, and I think currently they're looking for a consultant to be able to help them, to support them implement that activity in animal sector. We also monitor market complaints in terms of quality of products. That's just an example of one of the market complaints for one of the products in the market. And this was followed up to look at what is the root cause investigation and the corrective and preventive actions so that we don't have this kind of products on the market. We have also issued regulatory guidance for healthcare professionals on appropriate use of antimicrobial medicines. At the same time, we have issued regulatory guidance for the general public also on use of antimicrobial medicine. I'll just read for the public. One of the items say, the public is discouraged from self-medication with antimicrobial medicines. The public should only access antimicrobial medicines using valid prescription from registered pharmacy, chemist, clinic, and hospitals. And then it also says antibiotics are a class of antimicrobial medicines that are only effective against bacterial infections. Antibiotics are not the solution for infections caused by viruses, such as common cold or flu. The correct diagnosis and the decision about whether antibiotics are necessary can only be made by a qualified healthcare professional. The other one says the public should ensure that they complete the full dose of prescribed antimicrobial medicines. The other one says unused medicines should not be disposed of waste bins, but should be returned to the pharmacy or taken to the nearest clinic or hospital. The other one says antimicrobial medicines should not be stored at home for purposes of future use. I know a lot of us keep medicine in the house, and the public should not share antimicrobial medicines with friends or relatives. So all that is just guidance that is targeted to the general public, and it's part of the stewardship program. We told them about access to education, And then we also guided them that they only prescribe medicines by a duly registered prescriber, as outlined the Medical Practitioners and Dentists Act, and also the Pharmacy and Poison Act. So the law is very clear who should be able to handle and be able to deal with these products. So that is very important, and we continuously provide that kind of guidance to the public. And collaborations are very key, and these collaborations also speak to One Health. So we have collaboration between Ministry of Health, we have collaboration with Ministry of Agriculture and Livestock, county government, and that county is both MOH and Agriculture and Livestock, academia, like the University of Nairobi, and research institutions like Cambridge. We have the Fleming Fund, Cambridge and ILRI. For animal sector, we also have ILRI, International Livestock Research Institution. And for human sector, we have Kenya Medical Research Institution. So all those are collaborators. The Fleming Fund, these are development partners, the tripartite, which is WHO, OIE, and the FAO. The UNECTAD, that's the United Nations on Trade and Development. They are keen to see that we build capacity for manufacturing of antimicrobials in Kenya. So you can see all those collaborations. So all these come together, humans, animals, and crops, and the environment. And at global level, we have that umbrella. In that country level, we also expect that there's that collaboration and coordination. And even at county level and facilities level, we expect that there'll be that collaboration. And just to say, the national, we have the National Antimicrobial Stewardship Interagency Committee, what we call the NASIC, and we also have the technical working groups that work with the NASIC. This NASIC, the secretariat is a joint secretariat between the animal health and the human health. So we have people from the veterinary and we have people from the animal sector who sit in this joint secretariat. The same has been replicated in some counties already have started, and they are called County Antimicrobial Stewardship Interagency Committee, CASIC. And within these CASICs, there's also joint secretariats with the animal and human health sector. So that is very important for One Health and building of the governance structure that can actually support One Health. In terms of priority action areas for One Health, include one, translating data into action for capacity and continuous quality improvement. The IPC data that we're able to collect, the AMR data, AMU, use data, AMC, consumption data, all this data, we should be able to translate it into action in order to build capacity and also improve quality. Advocacy and awareness for healthcare services delivery. Like now we are doing advocacy. We are creating awareness about AMR in One Health. That's very important. The World Antimicrobial Awareness Week that's happening in November, that one is also another platform for creating advocacy and awareness. Then we have improved capacity for clinical and laboratory diagnostic services. As I had said, for you to be able to carry out good culture and sensitivity or antimicrobial stewardship, work, you need a proper diagnostic system. You need a proper laboratory that has very good investment in bacteriology and generally microbiology. So building that infrastructure and creating clinical laboratory interface, whether it is at healthcare facility level or at farm level for animals, that is very key for us to be able to build the stewardship capacity and programs. Then improved capacity for data management, analysis, and interpretation. It's just not generating data. You must be able to have a system that can properly manage that data. People who have skills and training to be able to manage the data, to be able to analyze the data, to be able to interpret the data, and finally to be able to prepare briefs, what we call policy briefs. Because for the cabinet secretary, you will not go with them with the raw data or very complex scientific data and present to them. They will not understand. So you must have a way of synthesizing this data and preparing what we call a policy brief. And for you to be able to do that, you need to be trained, and you need to build capacity for people who can be able to prepare those policy briefs based on evidence that we have generated as we generate data from the country. And then also advocacy and awareness, it's very important. Disease prevention, epidemiology, disease surveillance is very key. Infection prevention control is very key for us to prevent diseases so that we are not using or excessive use, so that we're able to prevent excessive use of antimicrobials. And that actually will help reduce, bring down emergence of new resistance and even spread of resistance. Then improved use of existing antimicrobial treatment options. We must optimally use what we have. We must observe the aware categorization. We must stop over-the-counter access of antimicrobials because that is a driver of resistance. And then we have to decrease transmission of resistance. How do we decrease transmission? Again, infection prevention and control, because that is another major gap in terms of what we call healthcare-associated infections transmission. And therefore, the only way you can stop this is having a very strong implementation of IPC programs within our healthcare facilities. So you can see we have the United Nations Development Program, the UNDP, which also has an interest in antimicrobial resistance. They talk about multi-sectoral responses to resistance. It has to be cross-sector, it has to be intersectorial. And then we also have the Antimicrobial Resistance Multi-Partner Trust Fund that actually brings together again the WHO, the OIE, and FAO. And this just goes to ensuring that we are combating the rising global threat of AMR through a One Health approach. So Fleming, how many of you remember Fleming? I'm sure you have read about Fleming when you study about penicillins, because he is we can say he's the father of antibiotics, because he actually discovered penicillins. And we know that the penicillin itself has been a major anchor in the starting molecule that has helped us to be able to develop and modify and come up with other molecules that have been useful as antibiotics. Okay, so he said, and that's way back he said that it's not difficult to make microbes resistant to penicillin in the laboratory by exposing them to concentrations not sufficient to kill them. And the same thing has occasionally happened in the body. So it's very important that as you treat, you have to expose to adequate concentrations that can be able to kill the pathogen. If you expose them to less than minimum inhibitory concentrations, the MIC, then you have a real risk of encouraging or contributing to resistance of the pathogens to this molecule. And this was predicted way back by Alexander Fleming himself, way back, many years ago, when we didn't even know about antimicrobial resistance. So you can see it's something that was predicted, and something that we have known for years, and yet people have not been able to follow this and put in stewardship programs. Okay. I will stop at that for now and entertain some questions. Over to you, Janice.
Thank you very much, Dr. Wanga, for that wonderful presentation. I'm sure we've all learned a lot. So this opportunity that we've been given is for questions. So if you have any question, you can feel free to unmute or type it in the chat box. So I also have a question about the stewardship, and especially like hospital stewardship, since I saw from that slide that you're performing very poorly in that sector. So what can we do as pharmacists to help and improve antimicrobial stewardship in hospitals, as far as like the antimicrobial stewardship committees are concerned? Dr. Wanga?
I missed a bit of your question, Janice. Do you mind just taking it again?
Okay, I'm asking about the antimicrobial stewardship, and especially like in the hospitals. So as we saw in the slide earlier, you said that we performed very poorly in that sector. So I was asking, as pharmacists, what can we do to improve on that sector, the antimicrobial stewardship, and especially the antimicrobial stewardship committees?
Okay, that is a good question. Some hospitals already have set up antimicrobial stewardship committees, AMS committees, and in countries which have been able to do very well in terms of stewardship, they have what we call pharmacy-led stewardship. The pharmacist provides leadership, has been in the lead position for stewardship. And it just explains because products, I mean, from antibiotics, antimicrobials, the pharmacist is the custodian of these products. And when they take the lead, especially the clinical pharmacist in the hospitals, then those programs are usually very successful. So some hospitals already have set up committees, AMS committees, and usually we would say that it should be, the chairman of that committee should be a senior physician who has a lot of respect, who can command respect from the other members of staff. And then the secretary usually is the pharmacist. That's the guidance that we have given them. And then of course you have someone from IPC, you will have someone from a nurse, disease surveillance, all those people come together from the committees. And we have seen, like Kenyatta, they have really a lot of work, committee, and actually they have been able to achieve a lot through the stewardship committee. We're encouraging other hospitals actually to develop a stewardship. So pharmacists have made actually secretary to the stewardship committees. Where there has been success in other countries like America and Europe, those stewardship committees are led by pharmacists. Over.
Well, thank you for that. So Jonah is raising his hand, so please feel free to unmute and speak.
Good afternoon, everyone. I'm a leader from Nigeria. Sorry, I'm late to the webinar. So I have two questions. The first one is on probiotics. Sorry, is there any role probiotics play in ensuring or reducing resistance? The second one is, are there research-based opportunities for student pharmacists who are interested in antimicrobial stewardship? Research-based opportunities like fund which students can access. Thank you.
Thank you for that question. And all the way from Nigeria, welcome. So the first question is probiotics. Actually, use of alternative treatments, and you know that probiotics are not antibiotics per se. They in terms of how they work, mechanism of action and all that is different. So I'll call them as alternative treatments and maybe complementary treatments. So those ones have been shown to be very, very useful for us to be able to slow down development of resistance. Because then if they are effective against some infections, we are saying that that will reduce the excessive use of antimicrobials. And we know that excessive use drives resistance. So the role of complementary and alternative treatments is very, very important in terms of us being able to control emergence of resistance against antimicrobials. In terms of research, I know in individual countries, there are many programs that are running. For example, antimicrobial resistance data, that already is an opportunity for research, because once you generate this data, someone has to analyze. You also need to compare maybe what are the resistance patterns in one region as compared to another region, but you should be able to have access to that data. For example, in my organization, we are looking at antimicrobial consumption, country level antimicrobial consumption. Within this data, as we generate, there are many parameters, many analysis that you can be able to carry out from just the data that you have. You can, for example, you can carry out aware how is Kenya compliant in terms of aware? Are we consuming more of access, or are we consuming more of reserve, or are we consuming more of watch? So as we generate this data, there are many research questions that you can have, you can be able to frame, and then use that data to try and answer those research questions. So there are many different level of analysis that you can be able to do based on the data that we generate. And another very good opportunity is point prevalence survey. I know in Kenya, for example, we have the Fleming Fund. The Fleming Fund is UK aid, United Kingdom, UK aid funded project or program. And through the Fleming Fund, we have been able to undertake quite a number of point prevalence surveys. And these surveys have been able to help us look at use, because you go down, it's a snapshot, you go down to a healthcare facility, maybe a regional referral hospital, and on one, you're able to go to a ward and look at patient files, records, check which antimicrobials have been prescribed, for which indication, for which duration, for which, the strength, and even the frequency, all that data. Then you collect that data in any laboratory investigation that be done for that patient, and any other concomitant medication. So all that, you can be able to carry out a point prevalence survey, and that will be very useful data in terms of antimicrobial use at healthcare facilities. So there are many, many opportunities that you can do. And one of the organizations that is doing this is the Fleming Fund. They are very, very involved in issues of antimicrobial resistance. They are in quite a number of countries in the world, and they also have fellows. Every year there's opportunities for fellows to undertake a fellowship program within the Fleming Fund. So that's something that you can be looking up to. We also have the MAP project, MAAP, the MAP project, which does more of laboratory work, and that is also working in a number of countries in Africa. We also have REACT Africa, REACT, REACT Africa. They're also doing a lot of work around antimicrobial resistance within countries. And I know they have for research. Thank you. Over to you, Janice.
Yeah, I have also another question related to AMR, but not One Health. So it's about the knee-jerk policy. Okay, according to a certain article I read, it was referring to it as the knee-jerk policy, whereby at the port, they withdrew the bodies that were there that were supposed to check the quality of drugs entering the country. They reduced it like from 30 to around 3. So I just wanted to inquire from your side as the PPB, what have you done like to step up the surveillance measures to ensure that at least whatever drugs we have in the market are of good quality? Dr. Wanga, did you get me?
I lost you a bit.
Oh, okay. According to a certain article I read some time back about a knee-jerk policy intervention at the port of Kenya, they were stating that they reduced the number of bodies that were inspecting the quality of drugs entering the country from around 30 to 3, which is very low. So I was just wondering from your side as the PPB, what have you done like to ensure that the quality of drugs we have in the market are of good quality?
Yeah, so I agree with you that monitoring products that come into the country at port of entry is very important, because then we can be able to intervene and stop anything that is not of good quality coming into the country. There was a policy decision that was made at high level that they didn't want many agencies within the ports of entries. That is the airports, the seaports, and other borders. That they also only wanted, I think, KRA, KEBS, and other organization. So that really threw us off balance, because medicines are not like any other products. require that we have to monitor and control any import and even export, so that we ensure whatever is on the country is of good quality. So I think the matter is being discussed at policy level, but as we speak, we still have our inspectors at the main ports of entry, that is the Jomo Kenyatta Airport and also the Mombasa seaport, and even at the borders, the land borders, we still have our inspectors who work closely with the Revenue Authority, the customs, and the KEBS to check anything that is coming to the country and anything that is going out of the country. In addition, we have a very robust post-marketing surveillance system to ensure that routinely we go out, sample medicines, and test in the laboratory to check the quality of those medicines, check whether they have been registered in the country, and also check whether they actually have proper import documents for them to have come into them. Thank you, over.
Thank you. I don't think we have any other question. So yeah, I think we'll be free to end the session here. Thank you very much, Dr. Wanga, for that wonderful session. Yeah, thank you.
We shall continue to interact. Thanks, participants. I know it is a Saturday evening. Young people like you might be having a lot of things to do on a Saturday evening, but yet you have sacrificed to be here. So let's continue with this momentum. Let's keep the fire burning. Let's be the ambassadors. Let's talk about these things openly. Let's advocate. Let's carry out advocacy and create awareness within our communities about AMR.
Yeah.
Thank you.
Thank you.
So thank you and bye for now.
Bye.